All right, I see people filing in. Welcome all. Get started shortly. Okay, great. So good morning, good afternoon, and good evening, depending on where you're calling in from. My name is Tanya Smith-Sreen, and I am a Senior Technical Officer with FHI 360, supporting communications and learning on the Playful Parenting implementation research. And it's my pleasure today to welcome you to our webinar, Playful Parenting, Enablers and Barriers to Scale, hosted in collaboration with ECDAN. We are going to jump right into it because we have a packed agenda today full of reflections from different presenters, and we're looking forward to a rich discussion on what it takes to reach impact at scale, contextualized by 4 case studies on scaling playful parenting programs in Bhutan, Rwanda, Serbia, and Zambia. So we look forward to the programmatic insights and the evidence-based recommendations from all of the presenters today. And with that, I'm going to run through the agenda. So we will kick it off with some opening remarks from Jill Popp of the LEGO Foundation, and then get into a presentation, including some background on the implementation research, and our definitions of scale. We'll then move into key findings by countries that were mentioned, present on the indicators of scale defined through the research, transition into a moderated discussion, and then we'll have some time for Q&A at the end. So before we dive into the agenda, I just have a few quick housekeeping items to cover. You'll see them in the chat as well. So today's session is being recorded, and the recording will be shared with registrants afterwards, along with all of the slides and other materials. As mentioned, feel free to submit questions in the Q&A box throughout the presentation. So you'll see that box at the bottom of your screen. Just make sure to submit through the Q&A box versus the chat, because that'll help us keep track of it during that portion of the webinar. And if you're having any technical issues, go ahead and message us directly in the chat. And with that, I will actually just stop sharing my screen quickly and pass it over to Jill Popp from the LEGO Foundation, Senior Research Specialist at the LEGO Foundation.
Great, thanks, Tanya. Hello, and welcome to today's webinar on playful parenting. I'm delighted to be with you here today. This journey of scaling parenting programs began 5 years ago, just as the world was entering a global pandemic. At the time, I could never have anticipated the depth and breadth of insights that would emerge from this work. At the time, we knew that playful parenting programs, despite their potential, often remain small, sometimes limited to pilot projects or localized initiatives, leaving many families without access to these valuable resources. To address this challenge, the LEGO Foundation extended an invitation to organizations globally. We wanted to hear from those with evidence-based programs that have successfully integrated playful parenting principles and demonstrated real impact on families and children. These organizations shared not only the results of their work, but also their readiness and commitment to expand, ensuring that more families can experience the benefits of play on a larger scale. I'm eager to hear from the team who has worked so diligently to bring these key findings to light. My hope is that the lessons shared today will be valuable and applicable to your work with families moving forward. Thanks so much.
Excellent. Thank you, Jill. I will share the presentation and pass it over to Karina Omweva from FHI 360 to start the presentation.
Thank you, Tanya. Thank you, Jill. And good morning, good afternoon, good evening, everyone. Thank you for joining us today. My name is Karina Omweva. I'm the project director for the implementation research study with FHI 360. First, some key facts about the study. As Jill mentioned, we started in 2020. For the past 5 years, we've been working in these 4 countries listed here with 2 objectives. One was to generate evidence on effective pathways to scaling up playful parenting. And number 2 was to serve as a learning partner to the grantees implementing these programs, as we were sharing evidence along the way and helping them learn from that evidence. So I want to recognize our broader research team that you see in the next slide. And so some of us are here today. There's a broader team and there are research partners in every country, and you will hear from some of my colleagues in a minute. Our study included 5 core areas of focus: child and caregiver outcomes as they shift and change at scale, community norms around parenting, particularly play, responsive stimulation, and father engagement, the frontline provider workforce experience as they expand, and then programmatic factors, and then the broader policy and enabling environment. We used a wide range of data collection methods, ranging from direct observations, surveys, in-depth interviews, focus group discussions, and outcomes assessments. And for child and caregiver outcomes, we used the home inventory and the generalized scale for early development. What makes our study interesting is the difference between these programs, as you can see in the next slide. The interventions that were being scaled varied and across the board in the types of providers they used, system actors or volunteers, modalities, home visits or group sessions, how frequent and intensive these modalities were, how they intended the caregivers to receive them, how much structure and play and responsive stimulation they included. And then they also ranged in the level of intended scale. So you can see we had nationwide scale that was in Bhutan, and then the experience in other countries ranged from two districts to 34 municipalities. And then when we define scale, we know that there isn't a universal rule of what is scale. Most systems serve hundreds of thousands of families. So we use the ExpandNet WHO definition, which is listed here, you can read it, essentially, which means take something that's been proven to work and expand its benefits to more people in a way that creates impact on a lasting basis. So there's an element of expansion and an element of sustainability built in there. And within that, we look at 2 trajectories. One is horizontal scale, which is all about expansion to more areas, more people. And then vertical scale, which is all about institutionalization and integration into the system with resources, resource allocation, human resources and systems. So with that, I'll let my colleagues share key findings starting from Bhutan. I think Karma, you're up.
Hi everyone, I'm Karma Choten. I'm the country investigator for Bhutan. As the country investigator, I was responsible for providing oversight and coordination of research activities and also facilitating local approvals and dissemination efforts in the country. So without further ado, let's dive right in. In terms of horizontal scale, after the initial implementation in 5 districts, the program was scaled to 15 districts, making it nationwide for Bhutan. With regards to uptake of the group sessions, we find that attendance of eligible families across districts stood at an average of 44%, with higher uptakes in phase 2 districts, which was about 50%. Low attendance has been an ongoing challenge for the program. So in order to drive participation, the health workers who deliver the parenting sessions in the community suggested that eligible families should be incentivized either in cash or kind to attend these sessions and take advantage of these sessions. For those caregivers who attended, at least for those caregivers who attended, at least one session predicts an improvement in responsive stimulation on the home inventory. This goes to show that participating in one session also helps child and caregiver interactions, with caregivers providing higher levels of stimulation through playthings and activities. So the next slide. Moving on to vertical scale, the issuance of the executive order from Ministry of Health indicates full institutionalization and continuation of these sessions in the communities. in all health facilities, which now include the hospitals as well. Also, there is alignment of the program with key flagship programs such as disability, mother and child health, which helps raise relevance and priority for the program itself. Likewise, the program indicators are integrated in the health information system, which is collated regularly to check for delivery and reach. With regards to workforce, the program is delivered by the health assistants who are part of the system with prior experience in primary childcare. They were trained using a standardized, structured parenting manual to ensure quality over at scale. Though it should be noted that regular monitoring and mentoring was a challenge and was limited during the program period and may require attention to maintain quality over time. This is especially so because the health workers report heavy workload and implementing over a dozen health activities in the communities. They report feeling overburdened and short-staffed. In terms of in terms of training, pre-service training has been integrated in the medical university's community health curriculum. Likewise, an online accredited course has been developed to ensure regular refresher training for in-service workforce as well. And with that, I come to the end and I pass it on to Michael.
Michael, we'll invite you to present on the Rwanda slides over there. Okay.
Yeah, thank you so much, Tanya. Thank you so much, Karma. Just like my friend Karma, I was responsible for providing oversight of the research activities, the research protocols, and permissions. Well, for the case of Rwanda, in terms of the horizontal scale, the program was implemented in 3 districts of Ngoma, Nyanza, and Rubavu. And by close to the end, they received funding to implement in the 4th district of Musanze. The training and regular supervisions, as well as the structured training, were very much appreciated by volunteers. These are volunteers who visit families because that was the core of the program. The program was also upheld equity by supporting parents, especially in the lowest socioeconomic status, and that was a big plus on the part of the project. Next slide. In terms of the vertical scale, there was absolutely strong commitment from the government as the program fits into the integrated early childhood development program that is implemented by the government. This is a huge program by the government, and most of the program components actually were very aligned with this initiative. At the start of the program, of course, there were multi-sector teams that were established to continue supporting the program. These constituted from government agencies, but also from actors in the early childhood development sector. However, at the end of the program, it was quite difficult to sustain these multi-sector teams in terms of the operations. And well, at the end of the program, it was also really, realized that there was a relatively lack of an exit plan, which would ensure continued support for the volunteers who really had done a great piece of work. Yes, some still do, but there could have been a very good exit plan if it were possible. Only 28% of the volunteers still continue to meet families and train them on various components of the ECD, of the program itself. And there's been very positive feedback from the government because, again, this program was aligned to government, initiatives. But the support did not translate well into integration, in the full integration of the program itself, and that is still a hiccup there. Thank you so much, Tanya. I think if there's anything else I could explain, but that's it.
Thank you, Michael. Yes, and feel free to add questions to the chat for the specific countries, and our country investigators can get to them during the presentation. With that, I'll pass over to Anya Haluga for the Serbia slides.
Thanks, Tanya. Hi, everyone. My name is Anya Hauda, and I served as a research advisor on all our activities in Serbia and Zambia. In Serbia, in terms of the horizontal scale, the Playful Parenting program was initially piloted in 6 municipalities and then expanded to a total of 34. It was a multi-sectoral effort, but a key component of the intervention was embedding playful parenting and responsive caregiving messaging into home visits routinely conducted by nurses. The nurses were highly motivated, respected, and appreciated in the communities, but given staff shortages, not surprisingly, many of them felt overworked and overburdened. Reaching all eligible families was a challenge, is a challenge, especially most vulnerable communities such as Roma families. Our data shows that only about 26% of caregivers of small children received visits that focused on play. And that is important when we consider the impact. Because our analysis of outcomes data shows that no difference is associated in parenting and child outcomes with a nursing visit overall, but we do see an increase in parenting outcomes if caregiver received play content during the visit. Now, the challenges with REACH were related to staff shortages, but also, which brings me to issues around vertical scale. Because the official schedule of visits concentrated on the newborn stage, and those early newborn visits were prioritized, and they often focused on breastfeeding and vaccinations more than other topics. A successful pilot for supported supervision was conducted, but it was not clear yet to what extent it could be institutionalized. Also, in terms of vertical integration, multi-sectoral collaboration was very strong at the local level within the communities where health, education, and social sector worked quite enthusiastically together on planning and coordinating playful parenting activities. And the program was very flexible in terms of what communities could choose as key components, things to focus on and dedicate resources to, which generated a lot of buy-in at the local level, but also posed a challenge for vertical institutionalization in terms of generating a clear understanding on what those key components of the policy are. And now I'm going to pass it on to Given to discuss some findings from Zambia.
Hello, everyone. I'm Given Hapunda. I'm the country investigator for Zambia. I'm happy to share with you vertical and horizontal scale for the care for child health, growth and development in Zambia. So the program operated in 2 districts of Eastern Province in Zambia, that is Katete and Petauke. The program was able to reach 36% of the targeted families, which also transitioned to group sessions modality so that we could expand reach. So this program first started with home visitations and then transitioned to group sessions. As a program which was delivered by community-based volunteers, we did find that community-based volunteers were generally satisfied with the program. We also found that the village leaders, who we call chiefs here, supported it, and parents generally expressed their interest for this program, which is very good for horizontal scale. However, we did find that lack of compensation and incentives for the workforce, such as transport, need for translation of the materials that they were using for home visits and group counseling, were not translated, making it a little bit difficult for them to implement, and the adaptation was also an issue. In terms of the impact, we did find no differences associated with the home visits. However, around 2.9 points differences on the home for those who participated in group sessions within the program districts was observed. Next slide, please. So in terms of vertical scale, we did find interesting, but also some challenges. First, I think the important thing here to note is that for vertical scale in Zambia, the availability of the CBVs, who are the workforce, is quite strong with a very good foundation in their communities. There's strong involvement also of the different line ministries that work in a multi-sectorial manner at all district level, and they're involved in training and implementation oversight in all the districts. So the multi-sectorial committee, which I've alluded to earlier, exists at all government levels, particularly at district level. It's quite strong where these programs are being implemented. However, there are concerns about attritions of the workforce. We are yet to know exactly the extent of this attrition. And mainly this is due to lack of incentives. A registry, although has been created under the volunteer policy to help to compensate some of the volunteers, we are still seeing a number of CBVs under this program who are not yet onboarded on the registry, still creating some concerns. But also the information management system is not being effectively used to improve quality delivery of the services. Most of the indicators are mostly output than outcome indicators. Thank you very much.
Thank you, Given. And I see some questions in the chat Q&A box specifically for Zambia, so I'll invite you to examine those. And back to Karina.
Yeah, thank you so much, everyone. So I think we just wanted to offer three key takeaways from the presentation, and we jump into the indicators of successful scale. First of all, is focusing on an effectiveness and scalability. So in other words, not trying to scale a program that it cannot be sustained with system resources, and it has huge implications for the way that what the program scales and the success and impacts it receives. Number two is ensuring government ownership from the start. It's absolutely crucial, as you heard from all of the country investigators, for the training, quality assurance, and retention of frontline providers. And then throughout the process is continuously examining the evidence and planning to adapt and iterate. And you'll hear from the experience of the programs how they did that. With that, I'll let Dr. Aboud introduce our framework of the key indicators of successful scale. Francis, you're muted.
My name is Francis Aboud. I'm the research lead with FHI 360 on this project. And yes, a lot of people have been looking at scale recently, and we're all trying to converge on an idea of what is the meaning of successful scale. So you know a little bit about our definition that includes both horizontal and vertical scale. So we have been interviewing government and other stakeholders over the 5 years. And in the latest interview this year, we directly asked stakeholders about horizontal and vertical scale achieved by the program. And from this, we derived indicators of scale. So they contribute to a global effort to address what we mean about successful scale. And you can see that the first question has to do with how has reach and coverage been expanded, in your opinion, and what is the evidence for this? So we have 4 horizontal indicators. The first one, yes, is demand. Is there evidence through attendance and advocacy that families want the program? It's not just about need for the program, it's that the families want the program. And this is really very difficult for parenting programs. The second indicator, horizontal indicator, was reach. Continuous expansion to new districts and all eligible families. You heard that many of the programs did not get over 50% reach, and that's sort of a difficulty. Some people have asked questions, and often it has to do with the fact that not enough workforce has been trained. The third is equity. This is very important that all eligible families, particularly vulnerable ones, have access to the program. And the fourth horizontal indicator has to do with the workforce. Is a sufficient number of providers being trained, retained, and supervised? And that's critical for reach, obviously. The question for vertical indicators was simply what activities help sustain the program once the resource team leaves? What evidence do you have for this? And the first one that came up, Tanya, was yes, multisectorality. Others who have talked about scale have mentioned this also. It's the idea that stakeholders from many organizations and ministries are engaged, not just often the Ministry of Health, but others are supportive right from the national down to the district level. The second is adopted. Is the government willing and able to adopt and implement the program? You heard that in Bhutan, this was indeed the case. Third is the policy and budget. Has the government sort of solidified the program with a policy framework, with a budget line that will sustain it over time? And the fourth is the program and the workforce integrated into the system, usually the health system, but not necessarily. Integration also means being integrated into the information management system to indicate that sessions have been held and so on. So yeah, now I'm going to pass it to our moderated discussion on what were the facilitators and the challenges to reaching scale in these 4 programs.
Great, thanks so much, Francis. So I wonder if the other panelists can also have their cameras on. And I guess question number 1, and we can start with Bhutan. As you reflect on your journey to scale, which indicators of horizontal scale from the framework has resonated most?
Thank you so much, Jill. Hello, everybody. This is Chitrim Tavge. I'm Chitrim Tavge from Save the Children Bhutan. We've been working closely for the Playful Parenting project here in Bhutan with the Ministry of Health, funded by Lego Foundation. So in terms of the indicators that Dr. Francis mentioned, we really resonate in terms of the horizontal scale for the demand that we have targeted. So taking a program to scale while maintaining the quality is a challenge globally. In Bhutan, we implemented the program in a very controlled manner, whereby we took it in a phase-wise manner. So you can see that there are different phases that we have taken up. Initially, we started off in the first 5 districts, where we took the opportunity to refine the program through a continuous process of monitoring, research, and learning conducted to generate evidences, evaluate the fidelity of the program and its effectiveness in terms of our services. While the program from Save the Children and the Ministry of Health have been continuously conducting these routine studies, we also had the external evaluator in terms of FHI 360 that evaluated the quality as we were going to scale, and found that we were scaling with quality and expanding it to the rest of the country in the remaining phases. As we were in the initial phase, we were actually reaching just about 30% of the intended target of our caregivers. That was quite less than what we were actually hoping for. But then as we implemented, gradually the reach has expanded. We started looking into really in terms of improving the demand and looking at why there has been low participations. One of the findings that we have also the implementation research revealed was that our messages that we aired through the national television, the social media, appear to have positively associated with positive parenting outcomes, and then awareness of our program. So the program also heavily invested in more time and resources in terms of developing program advocacy and awareness contents, and also the visibility videos that was again aired through the national television in order to with the aim of influencing the policymakers to commit in terms of sustaining the program, while also specifically focusing on increasing the awareness of our services amongst the communities across the countries and increase participation of our caregivers, both male and female, and of the young children that avail our services. So in a way, the demand was generated progressively through strategic implementation of our program, through systems strengthening, a lot of mass media campaign and communication efforts, and also a continuous process of improvement of the quality, thereby culminating in a sustainable and a nationwide model that is focused both in terms of rich demand and a supply for our children. Thank you so much.
Thank you so much. I hope that balance of supply and demand continues well into the future. How about Rwanda? Let's hear from you.
Thank you, Jill. Hi, everyone. My name is Gabriela Fend, and I work on the Sujira Muryango program based in Rwanda with Boston College, FXB Rwanda, and the University of Rwanda. So I'm representing the whole team today. And as you can see from our timeline, we have a very robust history in Rwanda conducting research on the Sujira Muryango program. And for us, the indicator that has really resonated with us is equity. Sujira Muryango really aims to address the needs of children and caregivers through customized and flexible family engagement through strengths-based in-home active coaching. And we do this by working with families who are the most economically disadvantaged in Rwanda through the social protection systems. So a very key component in our programming is that all eligible families, particularly vulnerable ones, have access to the program. And we do this by identifying families via social protection systems, the lists with the government. This system was called Ubudehe in Rwanda. And so we worked with local and national government to enroll all eligible families who fell under the criteria for the program. We also utilize a flexible home visiting model, which is a unique opportunity to meet families, especially fathers, where they are. Through this model, we work with families to identify the day and the time that works best for everyone in the family to ensure that everyone is attending. And so with this, we saw out of those 19,000 plus households, we saw on average 80% of male caregivers completing all 12 modules, with 42% of the fathers attending all sessions. And we also saw 98% of families complete the 12-week program. So we saw a really amazing rates of retention and just, meeting the families where they are. We also train the government's National Child Development Agency's Child Protection Community Volunteers. In Rwanda, they're called Inshuti Z'Umuryango, and they deliver our program. And the IZUs are an existing sustainable workforce scaled across Rwanda. And so our approach to equip the IZUs really focuses on equity because they're already embedded in the communities. And through training them, we strengthen, Rwanda's public systems and really value and empower the people who are already deeply connected to these families. So yeah, equity is a really core indicator that resonates with Sujira Muryango. Thank you.
Thanks, Gabby. Really interesting results as well. How about Serbia? Ivana, let's hear from you. What has been, what indicator of horizontal scale has really resonated in Serbia?
Thank you, dear Jill. Thank you for your question. Hello, dear Playful Parenting community. My name is Ivana Vojvodic from UNICEF Serbia. I'm really glad and happy that we gather today to exchange insights and our lessons learned when it comes to practices which are empowering parents and leveraging the transformative power of play in early years. So let's get an insight into Serbian parenting landscape from the perspective of the program REACH as an indicator of horizontal scale. I will talk about that starting from 2016 and 2018, when Serbia set the ground for the mainstream parenting support agenda by endorsing the National Program for Early Childhood Development and intersectoral call for action, which actually highlighted the key role and the leading role of the health sector in promoting optimal child development, but also the essential need for extended coordination among relevant sectors such as health, social welfare, preschool education, especially if we consider what is the persisting problem in Serbia, one of the persisting problems, that is the shortage of services and service fragmentation, for instance. So this was the turning point which enabled in 2019 the implementation of the Scaling Up Playful Parenting program, which was generously supported by the LEGO Foundation through existing platforms, existing services in home visiting nurse service, preschool education, social welfare in 20% of municipalities in Serbia. Now, this is where the practice of direct work with families shifted from one-size-fits-all treatment-oriented practice, which is focused on physical development, to a more responsive and caregiver-centered, gender-balanced practice, which relied on a whole new partner, whole new strategy, which has the potential to change people's hearts, minds, behaviors, and well-being, and that is play. So we arrived to 2020, where we faced, like the rest of the world, a very serious disruption of services. So the program, the Playful Parenting, really needed to innovate. So the teleworking modality was introduced within the home visiting nurse service, reaching during the COVID and some post-COVID time, 22,000 families. And also we started developing the content for digital aid, like Digital Parenting Companion, which is the Bebo application, which is now available in Eastern Central Asia and has over 1.5 million uptakes. In 2021 and 2022, I just said the program relied on a widespread network of services, but fragmented, facing shortage of human resources, who feel often overloaded. So services needed to join forces, firstly in 5 model centers in 2021, and then in additional 29 learning sites. And this went through a phased multi-level change. A national program was developed for capacity building of ECD professionals. Institutional building started, so cross-sectoral bodies within city councils were formed, local protocols, also function of learning coordinators was established to support master training, educating other colleagues and peers within single institution and within entire communities, and then afterwards amongst municipalities. Also, local strategic plans has integrated early childhood development and parenting support to enable programming of targeted measures. So in that period, we had as a result 100 new targeting measures in local budgets. In 2023, we also intensified work on updating pre-service curriculum in schools for home visiting nurses. And this is the period when around 1,000 ECD practitioners actually started to reach around 35,000 caregivers yearly with innovative practices, and that's a very important moment. This is the period also where the guidance for local self-governments on how to program these targeted measures across sectors to support playful parenting was developed, and then also the national level grants supported the implementation of these local measures. So in like 3-year periods from the public finance, around $4 million were allocated thanks to the advocacy of the program. So the 2004 was in the sign of the strong national advocacy for the development of the national plan of action across sectors that would operationalize existing programs and policies. A comprehensive benchmark analysis one was conducted, and now we can say that in 5 years we have an extensive network of champions of change who directly empowered over 93,000 caregivers, over 1,800 practitioners, out of which 300 nurses, and this number represents 25% of the total number of nurses in Serbia. 400 policy makers and so on. What I would like to highlight at the end, that we strengthened ministerial and local leadership, especially local self-governments, who showed passion and commitment to care about their communities from this perspective of caring about the caregivers. So they helped actually create the demand also for parenting support, and they triggered a stronger national commitment in developing costing national plan of action. The program continues to support local self-governments and the national level. We have with a stronger focus on more vulnerable families. I would conclude here. I'm open for further discussion in the next stages of the webinar. Thank you.
Thank you, Vani. That was a lot, but really informative in terms of the importance of the workforce as well. I'm sorry, in terms of reach. And then we'll head over to Zambia and Gibson. Gibson, I can't see if you're there, unmuted.
I think you're muted, Gibson. I see your video on.
Hello, colleagues. How are you? Yeah, I'm
Great.
Gibson. Yeah, Gibson Chimunya from Zambia. I work for UNICEF. Basically, I've been involved in this project from the beginning. So basically, I've been part of the implementing team. So I think one of the indicators that I'll talk about is the workforce. And I think from the beginning, I think I just want to say, I think this has been an exciting program. I think before we started the serious Playful Parenting, this was, you are seeing the map of Zambia, and where we have the interventions is Katete and Petauke, and that's where you have the blue paint there. But before that, before 2017, we were in 16 districts. But for this project, we focused on the two districts, and we concentrated on a few selected sites. As you can see there are 20 programming sites, basically, which started as the ECE community-based centers. But as we moved into 2019, when you started the Playful Parenting, we thought of increasing the interventions in terms of, if we have a site, how do we ensure that we have more services that we can integrate in one site? And based on that, I think one of the issues that we started to strengthen was the Playful Parenting. But I think what was really interesting is that because of the EC component, and we started dealing with the provincial health director, that is from the Ministry of Health. So one of the visits that we had to these sites, I think that is when one of the game changers started, because the provincial health director for Eastern Province just made a decision that all these 20 sites should be health outreach services. So meaning all the programs that the health colleagues are doing in those nearby clinics, and also the community-based volunteers, they are supposed to integrate them in what happens in those outreach services. So when we come to the workforce, because that has an implication on the workforce, because that had to be implemented by mainly the health staff, in terms of integrating the Playful Parenting and also taking it to the health facilities. So the starting point was training the health center supervisors, mainly those who are implementing the programs. They do all these under 5, but I think one of the key issues that was integrated in that workforce was for them to be able to 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 strengthen playful parenting. As they talk to pregnant mothers, as they talk to mothers who've just given birth, as they talk to those under 5, it's strengthen the play and communication within that package. So basically, that was one of the key components that started. So that playful parenting should not only be done in home visits, but as they go to the health platforms, we are able to strengthen this program. The next part in terms of the workforce in Zambia is mainly we work with volunteers, which we call community-based volunteers. And mainly these are the colleagues actually who do most of the health programs in the communities. So the next component that we had to strengthen was to train the community health-based volunteers in the CCD care for child development on how they can do the counseling with the mothers in the homes, so that the CBVs would do the counseling, would do the support in the homes, but also at health level platforms. So that is the programming that we did. But it also meant that for the health level colleagues, we had to train them in the supervision, give them the skills, give them the materials to be able to support the supervision of the CBVs at community level. So I think that is one of the positive aspects that happened in Zambia. But I think as the Dr. Hapunda has said, I think one of the key issues that we saw was how do we ensure that we change the methodology. I think as we said, you saw the issues, how could we reach more people, because the individual home visits, we saw that they could not be very effective to reach every caregiver, every parent. And that's why we came up with another methodology in terms of group counseling, so that one caregiver, one CBV, I think should be able to reach more caregivers. So basically, I think that is what we've done. But I think what is key now is the demand from, even if I'm talking about workforce, it's the other districts now that are calling for these saves to be supported, so that we can train their staff to be able to implement this program. I think for now I can end there. Thanks very much.
Okay, thanks. I like incorporating a little reach in there too. So workforce and reach maybe resonated as well.
Yeah.
Okay. I'm wondering also if you could reflect on one indicator of vertical scale now from the framework. What was most challenging and what would you do differently? We can head back over to Bhutan and hear from them.
Yeah, good morning and good evening and good afternoon wherever the participants are. My name is Lekhan and I'm representing Ministry of Health, work for Ministry of Health, Bhutan. So before I really begin, I wanted to again thank the team for inviting us to give us this opportunity to present our challenges and also showcase our successes. But just before I really go into the deep dive into these challenges, just a small couple of points that I want to make that I believe strongly contributed to the successes. One is the government was there right at the beginning to take over this program, so which was very important. Second was, as a government, we were able to define what is the impact that we'd have by doing this program. So perhaps this can be a lesson learned. So for us, what do you mean when you say impact? We are basically trying to reduce the multi-sector. We're basically trying to reduce the developmental delays in children, and we want to ensure that whoever the children grow up to be really in like with no developmental delays and no other challenges. So then there are so many other factors, and then we have the perfect workforces who are really suited. So we use our existing system, very robust primary healthcare system. So in terms of challenge, and I think we can have more discussions on this if there's any questions regarding this. But in terms of challenges, I would say there were a couple, but one of the biggest challenge perhaps is the multi-sectoral engagement gaps that we have had, because I mean, there were interest, and initially our success was because it was led by Ministry of Health of Government of Bhutan, and then the challenge here is it was seen as only the Ministry of Health's initiative, a Ministry of Health initiative. So then everybody thought that it's a Ministry of Health specific program. And then I think later on we realized that there were other agencies that were interested. For instance, Ministry of Education. We could have better perhaps leverage local governments to come on board to essentially help us with the demand generation, etc. So, and then there was also no, because of this, no multi-sectorality of this, there were no joint indicators that were set, and then there was no monitoring mechanism that was set that we can actually implement this. So this is some of the, and then again, in terms of policy, of course, like I said, there was no strong policy that really said that this playful parenting is not only a health sort of like intervention alone, that it can also extend to ECCD centers, etc. So these were some of the challenges. So what can we do better, in terms of this? What is a way forward? So I think we basically need to engage more essentially with the government sector, with other ministries, for ECCD centers, Ministry of Education, etc., and local government in terms of demand generation, in terms of service delivery, etc. And then also try to include this playful parenting into many of the guidelines, either in the guidelines of ECCD or the local government plans, and many of the outreach plans that is there for our local governments. And then I think we also need to work together with different multi-sectors to combine and integrate this playful parenting across and put it as a national agenda across different sectors, right? So, and then also, and then particularly focus on the cross-sectoral policy and maybe share the budget and resources and expertise wherever possible. So this is how we are really trying to go way forward with this. I think I'm up with the time, so please do ask more questions regarding this. We do have some ideas. Thank you.
I actually do have one follow-up question for you. I wonder, can you say how it was to be involved from the very beginning? Was it something that you were really on board with and thought that that would be valuable?
Yes, in fact, when Save the Children first reached out to you, because that time we were already involved in the C4 City Plus C4 City program as one of the some of the interventions, but it was not really strong because then parenting was always in, and like I said, for the longest time, I think Ministry of Health was there trying to really pilot and see what can be really beneficial. But then I think we were not really able to vividly describe and define what is the impact that is going to have when we implement this program, no? And perhaps I think and again, as a lesson forward, and I was just going through this presentation of different countries, that I realized that none of the countries actually really defined, because we are talking if you want to scale up, we are talking about in terms of playful parenting being scaled up across different, but what is the impact? No, that is what the government wants. That is what a lot of these agencies and a lot of these different agencies, what is the impact of this? So what is the impact on health, say, for instance? And for us, the definition and how it can benefit us is that it's going to reduce our development delays. And now we are also very specifically defining that we have with the new advent of rampant use of screen time, we are also defining that if we engage more interventions with playful parenting, and then engage in more play activities in children and use this as an intervention, then perhaps we can reduce speech delays, screen time, reduce the screen time usage, etc. So this is something that we need. And then Ministry of Health, to answer your question, Ministry of Health recognized this. The government of Bhutan recognized this as a very important intervention, and that's why we are on full board. And as a sustainability sort of like to sustain this intervention, essentially, we have incorporated this into our national policies, Ministry of Health policies, correction, Ministry of Health interventions, and we are going to sustain this. There are challenges, of course, in terms of capacity, in terms of demand generation, and this we're going to keep working on this to ensure that we reach a level that we want to reach.
Okay. Thank you so much. Gabby, I wonder if you wanted to talk about your indicator vertical scale that was maybe challenging or something you would have done differently.
Yeah, absolutely. And this does, tie into what Legden just described, because the Sujudra Mnyango program has the impact. It has a lot of research studies, but our more challenging indicator is how can that be adequately replicated in and integrated into government systems. So the indicator that was more challenging for us was adoption by government. As you saw from our timeline on the previous slide that we shared, we have had really clear intentions on maintaining and measuring the effectiveness of Sujuru Mnyongo through robust research studies. We have a really detailed quality monitoring and supportive supervision structure. We provide regular incentives to the home visitors and their supervisors. We have digital tools to monitor and evaluate the program, and a comprehensive implementation support system through FXB Rwanda and RC team structure, as well as really comprehensive local government engagement through a strategy that we called the Play Collaborative. And so while all this means that the program is implemented with high impact, we face the challenge about finding that sweet spot where the program is affordable and maintains its quality at scale with the government workforce. I think we all know that across projects and countries, what works in a controlled, well-funded setting, research design often doesn't translate easily into a public system or existing structures that might be under pressure or under-resourced. And so that's what we found with Sujuru Mnyongo. We have this robust history of conducting these research studies, but what can the government of Rwanda, actually adopt when it comes time to transition the program over? And so not necessarily what would we do differently, but something that we're doing now, and maybe we could have done earlier, is we are working with the government to create a light touch model of Sujuru Mnyongo. And we want to compare the high touch intervention, fully resourced, full of incentives and digital tools, with what the government of Rwanda can realistically deliver right now. And so we're calling that the light touch model. I don't have much more information because we're creating it now, but I think measuring impact and ensuring impact at scale is really important. And on the other side, making sure that the program can also be integrated is also important. So hopefully through this comparison, we can find that sweet spot of affordable, scalable, sustainable, but also maintains its reach and impact for families and children, because we don't want to lose that voltage. So something we're really trying to address in coming years. Thank you.
Great, that's really exciting to hear. Great, thank you for sharing that. Let's hear from Ivania in Serbia about your indicator for vertical scale.
Thank you, Jill. I would reflect on policy level change and related challenges as indicator of vertical scale. I would first just highlight that Serbia knew that the program needed to begin with the end in mind, and to take steps to design and co-design a pilot with high potential for future scale. In the meantime, the scaling process required community consultations with a variety of partners, co-design solutions. The scaling demanded actually constant alignment with changing government priorities. And it has been decided together with the government institutions, professionals and partners that playful parenting cannot be integrated in existing services in one sector, in one silos, but cross-sectorally. This cross-sectorality actually was a novelty and lacking mechanisms for exchanging data, strategies, working together for one single family, and also mechanism for monitoring quality and impact of services on families and their outcomes and child outcomes. So we were thinking what we could have done differently, actually in the context of persisting human resource shortages and resource variability. So maybe a tailored and more intensive advocacy for addressing these gaps nationally in human resources, addressing their burnout more intensively, addressing the polycystic crisis and migration of workforce from Western Balkans to developed countries, highly developed countries in the European Union. Another lesson learned was how to implement actually the redistribution of visits of home visiting nurses. Now in Serbia, we have 10 visits, one during pregnancy, 5 in the focus on newborn period, like in the first 15 days after delivery, and then 2 in the first year and 1 in the second and the fourth year. So actually, the policymakers, professionals concluded that redistribution of visit actually is required to be able to reach eligible families, so to have like less visits in the newborn phase and then more visits to fit other developmental stages of children and parents as they grow together. And towards the most vulnerable. So this redistribution was not possible at the beginning because we needed first to foster demand for that, create conditions for the government institutions, policymakers to absorb that idea, and to build capacities for age and development appropriate modeling of playful parenting practices with families. So we would like that happened before, but we think that it was not actually possible. What is still challenging is a changing political landscape. So we have on one hand local decision makers who really embraced this focus on playful parenting and cross-sectorality, but the national level commitment, while still high, is still struggling to find these feasible levers that can foster full playful parenting integration at scale in such an unstable political landscape. Thank you.
Great, thank you so much for that. And I think we'll close this out with Gibson from Zambia, if he could share some of his thoughts and reflections from Zambia.
Yeah, thank you very much. I think from Zambia, I'll look at it's still integrated in the system. I think one of the key challenges, even if from the beginning, I think I've said in terms of the political will, in terms of the government wanting to integrate fully this program, I think that is 100% assured. But I think one of the key issues that still comes out is when you look at the integrating in the health system and align it with the workforce, because you'll find that the workforce is really overwhelmed with, even if you go to under 5 clinic, even if you look at the workload of the community-based volunteer, they are all really overwhelmed with the workload. And that has an implication in terms of the quality, because if you look at a CBV who has to do so many programs within his workload or her workload, it really becomes difficult to ensure quality. So the issue is, how can we manage those challenges that we have in terms of ensuring that if it's integrated in the workforce, we have the workforce that can really implement the program. Though one of the issues that I didn't talk about, one of the key issues in terms of the workforce that we are doing is integrating the training into the different workforce. So like we've integrated that in the nursing curriculum so that it's not seen as an outside activity. So we have to look at how we really ensure that most of all these processes that really support the implementation of the program are really integrated within the government system, so that they are not seen as being outside the system. I think also one of the key issues I would want to talk is, we already talked about the workforce. To integrate it, we need, I have talked about the workforce. But if we are working with so many volunteers who are not incentivized, it becomes really a challenge. So it becomes really difficult to hold them accountable. But I think one of the key issues, I think that is promising, is that government now has really come up with a policy to ensure that CBVs are really incentivized. But though we have not reached 100% ensuring, but I think at least there's a policy and a good number of the CBVs are being incentivized. So basically, which makes it easier for them to be committed and to continue doing their work. But I think we may have challenges, but I think one of the key issues I would want to say is it's the demand that we've created and the need by government to ensure that this program goes to so many districts instead of just the two. And I'm happy that starting this 2025, we have increased to 10 districts, to 2 new provinces, based on the lessons, the learnings that we've gotten from the two districts, which is actually one of something that is encouraging. But also one of the key issues that we've been using, I think from the baseline, we've done the midline, and we'll be doing the end line of the INSACA program that we are doing. But I think the results that we are getting from that are really helping us in terms of advocacy. And I think we'll continue sharing some of those good practices that are coming from the two districts that we've been implementing. Over.
Thanks so much, Gibson. I think it's nice to hear from our implementing partners, how they're actually applying and thinking about this framework. I know personally, and Dr. Aboud, I may ask you a quick question if it's okay to kick off the Q&A. But I know for us personally at the foundation, having this framework has been really important at a key time when we're thinking more about going to scale with some of our partners and including new grantees. And so it's been really helpful for us to think about the horizontal and vertical scale and indicators of each that we can keep in mind for us as well. I wonder, Dr. Aboud, Francis, if you could say more about if there's one indicator that is maybe absolutely critical over the others, or can we just do horizontal scale? Do we have to do vertical? I wonder, Dr. Aboud, if you had any comments about that.
Sure. I know that most people who think of scale, they think about horizontal scale. They think about expanding their program more and more across the country or the region. And this is obviously very important because you need to adapt to new populations and think about equity and increasing demand, which often is not there initially. But vertical scale is probably the most challenging. And I think that frankly, we heard from Bhutan that working initially with the government to ensure that they are interested in adopting it once the quality and the impact and so on is there. I think that that's very important. And I think that working with the government right from the start, keeping them included, ensuring that you're raising their capacity to manage the program, working on policy and so on is important. So I would say foresight into and making sure that the government is interested and willing and able to adopt the program is probably a critical vertical. Possibly you'll work on other things once you know that the government is interested in that.
Great, thank you so much. I think this sort of wraps up the discussion, and I'll hand it back over to Tanya for the Q&A.
Great. Thank you, Jill. And thank you to all of our panelists for sharing those reflections. Really powerful to hear kind of how these high-level frameworks and indicators manifest themselves in programmatic experience and see alignments and commonalities across contexts. We really have a very wide or diverse geography here. So it's interesting to come together and really see how our experiences line up together and how we can share that out to the wider ECD community. So thank you for that. We concluded on talking about the indicator of workforce, and I saw we had a couple of questions in the Q&A specifically on workforce. I thought we could talk about that. So one was on attrition specifically. With regards to attrition, what would you recommend as a way forward? And the other one was on challenges overall, as it relates to achieving ECE agendas at scale. And so in response to that question, we really highlighted monitoring, supervision, and training as some of the core challenges. So since we left off with Gibson talking about the workforce indicator, and talking about how embedding training was a key focus of addressing that challenge, I'll actually pass it to another country that is focused on embedding workforce training into the system, and that's Bhutan. So Chitram, can I actually ask you to comment on the challenges of supporting the workforce through training, monitoring, supervision? I'll ask you to come off mute.
Thank you, Tanya. I'm sorry I'm not able to turn on the screen. There's some interconnectivity issues here.
Okay.
So, going straight into the issue around the workforce capacity building, I think attrition has initially been also a challenge here in the Bhutan, but in order to lessen this bridge this gap between the service delivery and in terms of services that we provide to our beneficiaries, we started so many different adaptations to our programs, such as, for example, in our program. In our program modality, basically our services are provided by the health workers who are also providing other health services, other critical health services to the communities. So as a part of their work, we have already made this playful parenting services provide through them. So what we did was we tied up our services along with one of their main health services that they deliver in terms of child development screening. So that is one way we have done it together. And also in terms of reducing the burden on the health workers alone, we also made the support staff within the health facilities available in terms of supporting the health workers in trying to take up some of the not very important sessions that we deliver through the Playful Parenting program that has to be done by the health workers themselves, but very small support that can be done by them. And then in order to also continuously keep on the capacity development of our workforce, through this program, we already trained all the in-service health workers in the country, and they have been trained basically on delivering these programs. But in order to continue this, we also integrated the playful parenting components in the University of Medical Sciences of Bhutan, through where our health workers graduate and study and then become the health practitioners and later on go on delivering these services. So they are already being, these modules are already being integrated, and then they will be studying on this. And then further initiative also in term has been taken in terms of making the playful parenting in component as an online accredited learning course for the health workers, whereby they can sort of refresh their knowledge and then around the playful parenting program, and then take on these courses to improve their service delivery. Thank you.
That's great. Thank you, Chitram. I'll just give an opportunity to Legden if there's anything else you'd like to add regarding supporting the workforce in Bhutan from the government side.
Yeah, sorry again. Like Citrim, my internet is not really good. But anyways, I think Citrim more or less covered the whole aspect of this. But again, just to add a small thing, we were always concerned about a lot of things, because one of the initial feedback from our health workers when we started implementing was that too many things are implemented through our health workers, and then like essentially it is our health workers who's actually delivering this program, and all our primary healthcare workers, our health practitioners, they have so many other responsibilities. They're also competing with immunization programs. They're competing with growth monitoring programs, IOSC programs, family health, family planning programs, etc. And every program is a very important priority for everybody, right? So then, how did we position the C4CD as a very important something that has to be taken up? So essentially, like we said, we did, in order to really get the buy-in, the program, we got to work with our development by Save the Children, and then generate evidences. And through our health workers, we released an executive order from the highest honorable secretary of the ministry, saying that this has to be there and this has to be implemented. So it's embedded, and our workforce attrition rate that Citrim was just talking about is across the whole board. But now what we have noticed is that the attrition rate is slowly reducing, not because of this program per se, because of other external circumstances. So it's slowly we are also covering up, and then we are also producing more health workers. And when we do produce more health workers, they are already trained. The added advantage is that we went further on to essentially incorporate this as a pre-service curriculum from the university, so from the supply side. So they are already trained, and then in order to ensure quality, as a program, all we need to do is essentially retrain them, give them refresher courses from time to time, whether online or in person. So this is something that we, and in terms of the preliminary training that we have conducted to almost all health workers. So we are quite comfortable in terms of the health workforce, but that there are other challenges, no? And then ensuring quality delivery is something that we are continuously working on. Okay, thank you, Tanya.
Thank you, Legden. Yeah, and thank you for touching on that executive order, which was a big win for the program in Bhutan. So exciting. You spoke about health assistants being overburdened or having a lot of other priorities that they have to be implementing. And this actually brings us to a distinction between the different programs within this implementation research study, right? So we have the program in Bhutan and Serbia that worked with health workers embedded in the system, whereas the programs in Rwanda and Zambia were working with volunteers. So, there are these opportunities with volunteers, and that maybe they're not strung up in the health systems programs, but there are other challenges. So maybe I'll turn it over to Gabi from the Rwanda team, to touch on the challenges related to working with volunteers, on monitoring, supervision. And there was a question in the chat on supportive supervision questions, that structures that you commented on. So I'll let you elaborate.
Yeah, absolutely. So yeah, in Rwanda, honestly, across Rwanda, there are really robust volunteer structures across every ministry and agency. There are 4 community health worker volunteers in every village. There are parasocial workers who help with graduation strategy. And we have the Inshuti Z'Umuryango, the child protection friends of family volunteers. So across Rwanda, there's just this really robust volunteer network, you could say. And so in every village in Rwanda, there are 2, a man and a woman, Inshuti Z'Umuryango, friends of family volunteer. And so a positive experience that we have is that this volunteer structure is scaled up across Rwanda. It's we're not creating new volunteers or anything like that. We're training an existing system, but they are volunteers. And so this isn't a full-time job. And so we've had a lot of conversations with the government of Rwanda on caseload, right? How many families can, IZUs for short, Inshuti Z'Umuryango, IZUs, can they reasonably visit in a given time period? How does this align with their existing roles and responsibilities? And so we also really tailored the program for this expansion to really align with the existing SOPs that the government of Rwanda had for the IZUs. So their mandate is home visiting, we do home visiting. Their mandate is child protection, we do child protection. they're integrating components of early child development. We have early childhood development. And so as something that's worked for us is like really aligning the program with the government workforce. But we still run into challenges. We can have a village where there are 10 eligible households and we're constrained with, you know, okay, we can only do 3 because that's the government wishes on how many families can receive the intervention at a given time. And of course, we have issues with turnover. There are volunteers. You can't force someone to be a volunteer forever. And also, you know, we want to support career development as well. If they can then get a job within other child protection spheres or for other NGOs or other programs, that's an amazing opportunity. So a challenge of continuous training for new workforces is also a challenge that we face with turnover and government capacity to do training. So that's something. I can also speak really quick on supervision. So something that we did to try to integrate supervision within the ISU structure more is really utilize the ISU coordinators. So in Rwanda, the administrative structure kind of looks like the village, cell, sector, district, national. And so there are cell and sector coordinators. And we worked with the National Child Development Agency to really try to build up their supportive supervision skills and their quality monitoring skills and their local government engagement skills. Before, the coordinators were purely in charge of just reporting numbers. How many families visited X? Okay. How many children videoed X? Okay. Send. And then that was their main responsibilities. So we are working with the government to provide more supervision training for the ISU coordinators. But this brings up other challenges of incentives for coordinators for doing more work and having more of, you know, of a defined skill set to be coordinators. So that remains a challenge as well for working with volunteers. Incentive structures, you know, fair pay for fair work, fair reimbursement for time, travel, etc., and turnover. Those remain challenges for Sujira Mnyongo as we try to scale the program.
Thank you, Gabi. Yeah, these are important points, right? As you're thinking about the workforce, it's not just about those delivering the program, right? It's about those supervising the workforce implementing. It's also about those providing monitoring and ongoing support to the workforce. And I know that Gibson also touched on incentives during his response in the moderated discussion. So it's an important consideration. And this is underway in Zambia, but we're still waiting to see how this manifests. There's an interesting question in the Q&A around political changes. So we want to shift gears towards that because I know a lot of our programs have experienced political changes during the life of implementation of the program. So any experiences in political changes, impacts and adjustment, and what impacts and adjustments were made? How do you deal with political changes in the country of implementation? What is the impact on scaling? And I'll direct this question to Ivana, since I know you all worked on a lot of multi-sectoral engagement and figuring out how to maintain that across these changes.
Thank you. Let me think. This is like a challenge that requires constant adaptation of strategies and tactics. And the good thing is that the program was conceptualized in this multi-sectoral way. So you always have people who are still maybe changing sectors, functions, domains of work, but are people who are highly motivating, who know what is the return in investment when it comes to playful parenting and early childhood development, who know what is the cost of inaction. They are just like changing their function places. So the program adapted in this way followed these champions of change. I'm speaking now about decision makers, and very often these decision makers in new political settings after changes were backed by professionals who we really knew well. So we tried to build also on that strength. What is important, it is a lesson learned, but also we knew that in the beginning, is to align and follow government priorities. So there are some priorities which cannot be like disregarded, so you build on that. For instance, in 2020, after the COVID pandemic, the government suddenly realized that mental health of a population worldwide, but also in Serbia, is disrupted. So we cannot speak anymore about play directly, or innovation, or applications, or something like that. But we can speak about empowering and fostering the well-being of population and the caregivers, so that they could be able to care for their children through play. So the program needed to adapt a little bit the language, the narrative, and to introduce some new elements, so that with the new settings in the government and decision makers, the capacity building program could proceed without any disruption. Also the advocacy, awareness raising activities at a high level. So this is all about really listening, adapting, reassessing, and networking. So an extensive network of people who actually co-design solutions, frameworks, competency frameworks, program strategies. Actually, they own this program. So no matter if they change function, position, or they leave the sector, they will always be a supporter. I am not sure if I can explain myself, but this is what actually was an enabler, an accelerator in this landscape.
Excellent. Thank you so much, Ivana. And I see that we are almost at time, so I'm going to thank all of our panelists for your contributions and reflections and really important work. We all stand to learn from your experiences navigating these challenges and these enablers and barriers to scale. It looks like we've answered most of the Q&A, whether it was spoken or written. We will share out the slides with contact information if you have follow-up questions. With that, I will just share the final slide and pass it over to Jill for concluding remarks.
Thanks so much, Tanya. And thank you to all the participants for joining today. I just want to close by thanking our implementing partners first and in-country research teams. You've been on this journey with us and embraced this as a true learning opportunity. I'd also like to thank FHI 360. When we first had the idea for this project, we wondered who would sign up for this. 5 countries, different interventions, and a community of practice could be a lot of data collection and management. Thank you for being up for the challenge, FHI, and doing such a great job. Finally, thank you to the entire ECDAN team. This network has given us the platform to share our learnings more broadly than we could have ever imagined. So thank you all. Thanks, Tanya.
Thank you.
Thank you. Bye.
Have a nice day. Bye.